welcome again to another edition of the Osteopathic Lyceum podcast. I have been informed of a place that I should look with respect to the outcomes of evidence-based medicine, or maybe a better way to say it is the impact of outcomes from an evidence-based medicine approach on patient outcomes. Because one of the things I had become aware of prior was that there was little to no information regarding the impact of the application of evidence-based medicine and then what that does downstream to patient outcomes. Because what you would want to know is if I invest time and effort and teach people how to behave in this particular way that would line up with what people would be happy with as far as the concept of evidence-based medicine, or the term, that I need it to be doing better than what is already done. All right, so I'm actually, please excuse me for just a moment. I'm going to adjust my microphone a little bit. It's working. I know it's working. I just want it up a little higher so that in case I mess up, things are okay. So hopefully you didn't get any of those spikes. I'm going to adjust it again. And there's going to be pops and spikes. Hopefully that doesn't bother you. No, it's not doing what I want. Thanks for bearing with me on this. I appreciate it. Thank you. So that should do a little bit better. It should come in cleaner. It might actually sound exactly the same to you, but when I'm looking at my soundboard, I'm seeing some different things. So I'm just trying to control the audio a little bit. Anyways, I was told I should look at practice guidelines, because practice guidelines, as far as I'm aware, based on what I've read so far, are aggregated information that you have reason to trust and that would then inform how you would approach things. Now, as far as I'm aware, based on what I've read, the primary approach to generate best practice guidelines is to use an aggregation of systematic reviews so that you primarily have more signal across more people such that you have more reason to trust it. One of the problems with aggregating signal and adding things together to try to get maybe more signal and less noise, as rough terms describing statistics, is that you're actually normalizing out the variance. And in clinical care, variance is very important. It matters a lot. So you maybe get stronger signal that a particular approach does a thing, but you're not necessarily appropriately noting who it doesn't do it for, as a reasonable way to say it. So it's a challenge, but it's a very reasonable place to approach it. So into Google Scholar I went, and I typed in best practice guidelines patient outcomes. So this doesn't mean it's a perfect search by any stretch of the imagination. This is just how the search engine within Google Scholar works and what it provides me initially. It doesn't mean these are the best places to look by any means. I'm not going to suggest that this is perfectly representative of what the heck is going on. But anyways, I'm going to read a couple of abstracts, and then I'm going to go into a paper that I've had the chance to look at that shows some of the challenges, and it does a good job because it's being honest, right? So the first one is the effects of clinical practice guidelines on patient outcomes in primary care, a systematic review. And this is from 1997, so this is old. What you would assume is that over time, people have learned from what they found from systematic reviews, and maybe that applied learning into the base experiments that would then be aggregated into systematic reviews, such that the base scientific behavior gets better. So then you can have more faith and better evidence with respect to what would be identifiable by a systematic review. So really quickly, again, the effects of clinical practice guidelines on patient outcomes in primary care, a systematic review. Objective: to assess the evidence for the effectiveness of clinical practice guidelines, CPGs, in improving patient outcomes in primary care. I don't need to tell you about the data sources, study selections, Studies of the use of CPGs were selected if they involved a randomized experimental or quasi-experimental method, concerned primary care, were related to clinical care, and examined patient outcomes. Of 91 trials of CPGs identified through the search, 13 met the criteria for inclusion in the critical appraisal. So no matter what happens, when you set forth to do any form of meta-analysis, whether it's a systematic review, a scoping review, or any other form that I'm not going to name, because I don't remember the names, not because it's impossible, but because currently I don't remember them. And really, the rigorous ones are systematic and scoping. But you're going to have to acknowledge how many you found based on your search terms, how many you included, and why you included them. So you are acknowledging that you are purposefully narrowing to try to answer a specific narrow question so that you can improve the signal to aggregate the concept and amplify and apply or be able to make a claim over a larger patient population or a larger population than was included in each study that was included or each trial that was included. You're trying to magnify, and that's fine. But in magnifying, you've made value judgments of what matters because you're asking a specific question. That means that you're taking it further away from clinical practice because clinical practice will have other factors that are more important in the patient that matters more than anything that could be said about a population they might fall into for reasons that have little to no control, right? You're in a population by accident, more or less, right? Data extraction, blah, 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 blah. Don't worry about that. Data synthesis, most common conditions studied were hypertension, 7 studies, asthma, 2 studies, and cigarette smoking, 2 studies. 4 of the studies followed nationally developed guidelines, and 9 used locally developed guidelines. So now this is early, so I'm not going to say that this is indicative of what's happening now, but there's a variability in the guidelines, right? So the guidelines are developed by different groups for different reasons, and that has a challenge. 6 studies involved computerized or automated reminder systems, whereas others relied on small group workshops and education sessions. Only 5 of the 13 trials, 38%, produced statistically significant results. Conclusion: there is very little evidence that the use of CPGs improves patient outcomes in primary medical care, but most studies published to date have used older guidelines and methods which may have been insensitive to small changes in outcomes. Researchers needed to determine whether the newer evidence-based CPGs have an effect on patient outcomes. So they tried to do it. They acknowledged that the guidelines that were being used were old, and they're saying that, hey, we need to look at newer stuff. So it's honest, and it notes the variability. This is a thing that's going to happen in almost any form of meta-analysis. There's going to be variable data collection, which makes it hard to actually make a claim because the math becomes hard. You've got to translate in a way that's consistent, reliable, and defensible, and it's not easy to do. So the next one I want to take a look at, so that was from 1997. This bumps up to 2009. Effects of evidence-based clinical practice guidelines on quality care, a systematic review. So we get another systematic review. Again, 2009. Background: evidence-based clinical guidelines aim to improve the quality of care. In the Netherlands, considerable time and effort have been invested in the development and implementation of evidence-based guidelines since the 1990s. Thus far, no reviews are available on their effectiveness. The primary aim of this article was to assess the evidence for the effectiveness of Dutch evidence-based clinical guidelines in improving the quality of care. Methods: systematic review of studies evaluating the effects of Dutch evidence-based guidelines on both the process and structure of care and patient outcomes was conducted. The electronic databases Medline and MBase 1990 to 2007 and relevant scientific journals were searched. Studies were only selected if they included a control trial, an interrupted time series design, or a before and after design. So when you're looking at things that have different designs, your ability to make that into meaningful signal has challenges. It's not impossible, but your confidence in what you say can be questionable. Even if you see something when you run the stats, which are appropriate for the analysis, because these are different things, they're being experimented on in different ways, your ability to say something about it is limited. It's not impossible, but it's limited because the designs are different. So when you undertake a meta-analysis of some form, there are flaws built in because you're not comparing things that are meaningfully enough similar. What you're going to do is you're going to make choices as to what you will consider similar enough or properly related to what you're trying to figure out. They're defensible, but that doesn't mean that they're necessarily strong. And maybe they are strong, but if you can't figure out what the heck is going on, you're going to have a problem, right? Or you're going to have high confidence that that they did something meaningful in a way that if it has a flaw and you can't detect it, you have a problem. Right? Results: total of 20 studies were included in 17 of 19 studies that measured the effects of the process on the process or structure of care. Significant improvements were reported in process or structure. Okay. 13 of these studies reported improvement with respect to some of the recommendations studied, so not all of the recommendations. Okay. In addition, the size of the observed effects varied largely across the recommendations within the guidelines. 6 of 9 studies that measured a patient health outcomes showed significant but small improvements as a result of the use of clinical guidelines. Okay, so we actually have something that was looking at the guidelines themselves and patient outcomes. I can't tell immediately if it was including previous standard of care versus the application of the guidelines. I would want to see that and I would want to know that, but at least there's some signal here. So my confidence can go up and I can meaningfully decide to look for more. Conclusions: this review demonstrates that Dutch evidence-based clinical guidelines can be effective in improving the process and structure of care. The effects of guidelines on patient health outcomes were studied far less and data are less convincing. The high level of variation in effects across recommendations suggests that implementation strategies tailored to individual recommendations within the guideline are needed to establish relevant improvements in healthcare. So you're going to have to develop more guidelines and you're going to have to teach people how to do them specifically. Moreover, the results highlight the need for well-designed studies focusing on the level of the recommendations to determine which factors influence guideline utilization and improve patient outcomes. So we got to do more studying. Fair enough, but you're seeing that at least on the level of the patient outcome, there's less than there is on the implementation process and structure of how this is being rolled out. Something I can comment on here so that it's at least part of the discussion that you're going to listen to as I continue on here is that medical error research shows a similar phenomenon with respect to standardization. Also, findings within osteopathic manual therapy with respect to palpatory diagnostics shows a similar phenomenon. If you standardize approach, there are less errors and there is more agreement. So the question is, are we really seeing in any way a phenomena about evidence-based medicine specifically or the best practice guidelines, or are we seeing an effect of standardization? Standardization may be the better category. It may not be. You could convince me if you showed me that in almost all cases, when you looked at previous standard of care versus the best practice guideline, which you could then translate to evidence-based medicine because it needs a translational step, best practice guidelines are not necessarily as a construct evidence-based medicine, but they can be argued to be related well enough that if you look at one, you're seeing the other. And I'm okay with that. But are you really seeing evidence-based medicine, or are you seeing standardization of approach? Because in a multitude of phenomena that I know about, standardization of approach improves agreement and reduces errors. So I don't know that I'm seeing evidence-based medicine per se. And if the actual proper category or the proper construct is standardization of approach, then evidence-based medicine now washes out and is not required because there's a better category that explains more and assumes less in the form of just a standardized approach. Okay, let's go on. Outcomes of evidence-based practice. Outcomes of evidence-based clinical practice guidelines, a systematic review. I didn't look at that one for you guys already. Really quickly, objectives. Study aimed to investigate whether evidence-based clinical practice in healthcare improves outcomes for patients, personnel, and organizations. That's a lot of groups, and this is from 2004. So I'm not going to look at I'll look at the results to try to be expedient or quick. Of 305 assessed articles, 8 studies were included. The outcomes in the included studies were related to the experiences of patients and personnel, and to organization concerning changed patient care and resource utilization. How'd you use the money different? How'd you use the Band-Aids different? How'd you use the drugs different? How'd you use the syringes different? How'd you use the defib different? Because the included studies are heterogeneous in design, they're different. Heterogeneous, different. Focus of research area and scientific quality. The scientific foundations for the findings is weak. There is some support that evidence-based clinical practice guidelines, when put to use, improve outcomes for patients. Less likelihood of showing worsening of skin condition and disruption of skin condition improves more rapidly for infants, for personnel. support in daily work situation, 3 for organizations, decreased admission rates and length of stay, less resource utilization, and reduced costs. One of the things that you can say is the standardization of approach improves the ability to discriminate between who needs something and who doesn't, such that you are more appropriately utilizing the resources. It also likely, you could predict that the employees or the workers or the healthcare practitioners that are using a standardized approach may feel more empowered and may feel more certain, so they'd like it better. Uncertainty doesn't feel good, but it's a highlight of any form of healthcare practice. To read the conclusions, and again, keep in mind this is 2004. This is not new, so there may be more learning, more accuracy, more base level research on the application of best practice guidelines and patient outcomes. Right, that may be possible, but this is what this says. Conclusions: there is a need for further research as the findings are based on a rather limited number of studies. There is a tendency towards support for the idea that outcomes improve for patients, personnel, or organizations if clinical practice in healthcare is evidence-based. That is, if evidence-based clinical practice guidelines are used. I need you to translate that as, well, okay, I don't need you to do it. I'm going to do it because I think there's value in it. Evidence-based practice guideline could be replaced by standardized approach, right? Standardized. How do you build the standardized approach? Well, you use the best available evidence. Ooh, that's supporting evidence-based medicine. No, it's not. It's how anybody would do it. Quality improvement. The field of QI would tell you, go find the best evidence, try to apply it, and iterate if you can. Or because you'll need to, maybe is better. So this doesn't necessarily support evidence-based medicine in a parsimonious way, assuming less and explaining more. It's really pointing at standardization of approach. That's the argument I'm going to make. I get it if you don't agree with me. If evidence-based clinical practice guidelines are used, although these findings could be specific to the settings and context of the studies reported in the systematic review, it always is. Right? No matter how you study something, whether it's multi-center or whether it's one center, you always have the limitation built in to the how it's applied based on a lot of factors that you're not necessarily considering about the location or locations of application, because that's how the evidence is generated. It's not generated everywhere. It's generated in the specific places you studied under the restrictions that you tried to generate it. So the answers are always narrow, even when you try to amplify it through something like a meta-analysis. It doesn't mean there's no value. It just means you have to know the limitations and the narrowness of the damn stuff. There's one, what's the next one? 2008, outcomes research generating evidence for best practice and policies. I've looked at this quickly already. It's not necessarily going to do much for the conversation. So, hey, active inclusion-exclusion criteria. Look, it's good evidence-based medicine practice. Clinical practice guidelines, the good, the bad, and the ugly. This is the newest one in this search. So I'm going to do this, and then I'm going to move on to the other one, the one that I ended up looking at the full text. So this is clinical practices, the guidelines, clinical practice guidelines, the good, the bad, and the ugly. And this is from 2023. This one ends up giving you some snippets. So you get the full abstract and then you get some snippets. So you can see some more stuff. You don't necessarily see the full text easily. I didn't try to get it, but it does a decent job even in the abstract. So clinical practice guidelines, CPGs, play a fundamental role in improving healthcare and patient outcomes by helping clinicians make the best evidence-based decisions for their patients in a time-efficient manner. By following the available methods and criteria to create trustworthy CPGs, panel members can develop high-quality guidelines. However, despite the improvements over the years, CPGs are still subjected to biases and limitations, with conflicts of interest being the ugliest problem. GCPs? Oh, I was typing. That must be a typo. GCPs. It's supposed to be CGPs. Must face. In this review, we discuss the main characteristics of clinical practice guidelines, their pros and cons, and the future challenges they need to overcome. So just to read again and to read a little more. Clinical practice guidelines, CPG, are statements that include recommendations intended to optimize care. They are informed by a systematic review of evidence. When you say they are informed, you could argue that that means that it's not the only thing, but systematic review is the thing that's mentioned. It's the top of the hierarchy to create the CPG, and then the CPG trumps the meta-analysis because it's it's an aggregation of aggregations. By by a systematic review of evidence and assessment of the benefits and harms of alternative care options. The principal benefit of guidelines is to improve the quality of care received by patients by promoting interventions of proved benefit and discouraging ineffective or potentially harmful interventions. Here's my problem with that. The physician has to be skilled enough to judge whether or not the standard approach is going to properly impact the person in front of them, or if they need to consider alternate approaches. Also, if you take this approach, taken to reductio ad absurdum, so reducing it as absurdly as possible, no innovation will follow. There will be nothing to study. The counter argument would be that, well, if we don't see much evidence supporting anything, then it's a ripe ground for promoting innovation. If you're always looking for the aggregation, then the error you're more likely to fall in, because you have a preference, is that you're less likely to innovate and more likely to look to other people that you believe you trust for the information. The physician, unfortunately, needs to be most free to alter things. EBM practitioners or EBM supporters would say this is where clinical expertise comes in. But if I have primed somebody to look for the CPG, I have primed somebody to look for the meta-analyses, then I have primed them to look away from the base level experimental approach that is the highlight of any form of clinical decision making and the highlight of any form of treatment intervention. Unfortunately, it doesn't mean it does that. It just means that the fear, the concern is that it primes them to look at the big data and not look at the singular data point in front of them. You could call it an attempt to reduce errors, but there's so much frill in this stuff. It's so rigid that it's not that it tries to remove innovation. It just might make it cognitively harder based on preferences, hierarchies, and priming. Where did I stop that? Guidelines can also improve consistency of care, empower patients, influence public policy, drive the development of disease performance measures and evaluations, and direct the planning of high-value interventions. Yeah, I mean, fair enough, sure. Nothing to say there. Guidelines in their current form were introduced in the 1970s based on expert opinion. Although they started from the review of existing scientific evidence, the link between recommendations and the quality of evidence was often difficult to establish. The emergence of evidence-based medicine in the 1980s led to more rigorous methodologies for guideline development, emphasizing research evidence over opinion. Fair enough. I see no problem with that, right? That sounds like a good idea. In 1990, the Institute of Medicine, IOM, published a report that aimed to encourage more standardization and consistency in guidelines development, which was updated in 2011, properly cited. According to this, to be trustworthy, guidelines should be. So anything that follows is axiological. It is value-based with respect to choices and preference made by whoever had an impact on the statement. It doesn't mean it's wrong, but you benefit from understanding that there are values permeating, dripping through all of this that you may or may not agree with. They're probably good, but you will benefit from considering the values that are held here. Be based on a systematic review of the existing evidence. Holy crap. Oh, it's always systematic review first. Systematic review. How can you get good information out of a good systematic review? You need good base level science being performed. Good base level science is going to trump these goddamn systematic reviews every time, because every time they do a systematic review, they're looking at what's already been done. So if they have low quality, the systematic review has no choice but to be based on low quality evidence or medium quality evidence or stuff that they're going to critique. Like, the base scientific skill is so much more important than these damn systematic reviews. If the systematic review tells you that the evidence is maybe not trustworthy or that it's medium quality, then why the hell would I trust any guideline from the damn systematic review? I need to go back to basics, do better science so that the systematic review people can do a better systematic review. The systematic review is after the basic science. Like, please. I'm going to do something here that somebody might appreciate. Because you can tell that I would assume you could infer that I'm showing a little bit more frustration right now, I can use some big fancy words to say something that I don't want to say colloquially right now. Based on how this stuff is going, I think I'm going to drop all my fecal matter on the floor, misplace it, and not be able to find it again. Okay? Interpret that. Knowledge translate that. Like the first damn thing here, it should be based on a systematic review. What about being based on sound goddamn science? Like, go do the sound science. Stop telling me to do systematic reviews. They're good sometimes, but holy crap. Be developed by a knowledgeable multidisciplinary panel of experts and representatives from key affected groups, stakeholders, okay? Stakeholders are going to be exceptionally important sometimes, but if you're trying to do something that's technical, bringing in non-technical people can mean that the technical aspect gets negatively impacted. You can bring people in that are non-technical to impact what happens with the application of the technical stuff once the technical stuff is high quality, okay? Consider important patient subgroups and patient preferences as appropriate. Okay, as appropriate's fair. The reason they had to put this in here is because most of the time when you take disaggregated, dissimilar approaches and put them into a systematic review or a meta-analysis, you're washing out the key factors about patient populations. You're just looking for the big signal. So they had to put this crap in here because they have to acknowledge that they're missing things like severity of symptoms, things like variable presentations, things like variable characteristics of the patients. It's gone. Meta-analyses wipes it out. So they're saying we've got to include this now. We've got to do it because we're screwing up, right? Be based on an explicit and transparent process that minimizes distortions, biases, and conflicts of interest. That is, we're positivists. We need to minimize the impact of the individuals present because that is our value, and we're trying to create the view from nowhere. I'm in support of that. I get it, right? Next, provide a clear explanation of the logical relationships between alternative care options and health outcomes, and provide ratings of both the quality of evidence and the strength of recommendations. Okay, so is it good, bad, okay, medium, whatever? Create a damn rating scale and let's go. But they're going to tell you this based on magnified data and magnified signal that is going to make it easier for you to turn away from when that option is the best for your patient. Okay? They're not trying to. This is good faith, but it messes with you. It messes with your ability to make clinical decisions. Final point here, be reconsidered and revised as appropriate when important new evidence warrants modifications of recommendations. Awesome. Fantastic. Beautiful. Although these criteria were highly disseminated and used for guideline developers to improve the accuracy of guidelines, many current CPGs suffer from biases and limitations. The first bias is related to the panel composition, which often does not consider financial, professional, or intellectual conflicts of interest. That's cited. Besides, guidelines are often too narrowly focused on single diseases and hardly ever consider patients with rare conditions or comorbidities. There you go. I said it already. Sorry for the sass. Sort of. I feel the sass. It's emanating. Hence, for most of the patients, guidelines do not allow individualization of care. SAS activated. Consequently, furthermore, the quality of individual scientific studies and systematic reviews is variable. Consequently, CPG recommendations often rely on low-quality evidence or expert opinion because you need the basic science right first. We don't need to teach EBM now. We need basic science now. EBM could be in the future, but if you only teach people EBM, they suck at basic science. Come on, man. These are skill sets. These are narrow things. Like, if you don't understand cognition, you won't understand why this is a problem, or you'll have a much harder time. Additionally, most guidelines are scattered across journals or websites from individual countries or health organizations, making it difficult for clinicians to find and apply them. Finally, most guidelines become outdated after 3 years, and most guideline developers lack formal procedures for updating their guidelines. Okay, so why in the hell am I going to now increase my confidence that I should be looking at, clinical practice guidelines? Somebody this is 2023, they just told me all the problems, which I predicted. It's disaggregated. It's dissociated where you're going to find me saying this. You're going to have to go and look. I'm sorry. But this is stuff that I've pointed to having never read this. Okay? These things from first principles are not hard to see. If you are an ardent adherent to EBM, these problems exist and you're not doing a good job dealing with them. Yeah, so there's a new set of recommendations and systematic reviews first. Like, get over it, man. Yeah, systematic reviews magnify the signals, but they also ignore the variance in the patients. It's just how that works. The flaw is built in. You can deal with it. And the retort would be, well, we try to teach people how to deal with other forms of evidence, so they should be going and looking at it as professionals. But just stop it. Ugh. Sorry. Maybe. Again, maybe I'm sorry. Who knows? I know. It's like the lousy Canadian part of myself. Sorry, not the American part. The American part would rather continue to lose all my fecal matter and not be able to find it. Guidelines, improve patient outcomes, specialized mental health care, systematic review, and meta-analysis. I think I'm just going to, just for timeliness, try to read only the abstract. There's a bunch of stuff in, maybe I shouldn't just read the abstract. I should get into this a little bit more. I'll try to be as timely as I can about it, because in the abstract it says certain things and then it's sort of not representative of what's properly written in there. It's a challenge with reading abstract. So anytime I read only an abstract, I admit that I'm only reading the abstract, and I'll also admit that there are things that might be contained within the paper that I can't identify. So maybe what I'm judging is incorrect because I'm missing something. If you listen, that's what I do. And I know I do it because it's me all the time. I'm not going to... okay, maybe I'll read the intro a little bit. In the 1990s, the majority of people with common mental disorders who visited a mental health professional in the United States, Europe, and Australia did not receive effective treatment. This finding gave a new impetus in the development and implementation of evidence-based guidelines in mental health care. Mental health is multifactorial. You're going to see variety generally. That variety could be argued to be responsive to the patient, responsive to the preferences of the practitioner, and also responsive to a lower knowledge base in the 1990s or prior to the 1990s. If you increase the knowledge base, these things tend to aggregate because you will have people who are very knowledgeable and will try to synthesize this anyways and try to run it through education systems. This finding gave a new impetus in the development of implementation of evidence-based guidelines in mental health care. The policymakers and professionals of many countries became aware of the suboptimal quality of mental health care and tried to improve this quality by reducing treatment variation using a set of evidence-based guidelines. High-minded, good faith, trying to reduce variation. I understand the drive. The problem is, what if the variation is the key to driving positive mental health outcome? You have just attempted by policy to minimize that. You would argue at all times that we never said, don't vary the treatment based on the patient. But if the top-down thing is minimize variation, let's argue that maybe people will be primed in the direction of just following the damn guideline. And guess what? If you set a policy and people have licenses and they don't follow the guideline, what can you start to do to them? You can start to give them trouble for responding to their patient in the way they see best fit and mess with their license. So that could be a problem, right? Okay. By combining the best available scientific evidence from randomized controlled trials with recommendations based on expert opinion, evidence-based guidelines may serve as a tool to deliver optimal mental health care. This position holds only when three important conditions are met. The organization of care needs to be adapted in order to enable professionals to deliver care in accordance with guidelines. 2, professionals must have the knowledge and capacities to execute the guideline recommendations in clinical practice. And 3, patients must accept the care they receive following guideline recommendations. Do you not see the challenge with this? There are conditions set on this that, because people are involved, are an immediate challenge. People are the ones that will set the policies, and then the patients have to come on. Sorry. The uptake of guideline recommendations appears to be difficult, leading to a gap between the theoretically available evidence-based treatments and recommended in existing guidelines and their use in routine care. Adherence to mental health guidelines may be improved by so-called multifaceted interventions aimed at guideline implementation in daily practice. The implementation of evidence-based guidelines, however, is complex. Barriers at the organizational, professional, and patient levels may prevent everyday use of guidelines. In addition, because the implementation of guidelines requires investments in time and resources, policymakers are able to distribute them only with the underuse of these guidelines as a consequence. In the midst of the discussion, you have to teach them. You have to teach people how to use these guidelines because it's not already part of their clinical practice. You have to teach them something new, which means that you have to consider how people adopt new things, how they use new things, how they're low skilled in new things until they've done them for a long time. Like, if you don't have good teaching practice, this won't work. Like, this is not a thing that works. It doesn't line up with how clinical decision making happens. It doesn't also acknowledge that newer practitioners are going to have more of particular forms of issues. It also doesn't identify how experts are going to go through a career and learn what works most of the time. Therefore, the error of the expert is using the thing that works most of the time, even when they should change, right? Trying to standardize makes it easier to screw things up in predictable ways. Having no standardization means that you have no ability to communicate clearly and explicitly on what's happening, but there's problems with both. If you can't communicate on a standardized approach, then you're going to have more handover errors, more team-based errors. If you have a preferential approach, that means that anytime it's outside of that preferential approach, you're screwing up, okay? So the errors are consistent in all approaches. They're different forms of errors. They're predictable. In the midst of the discussion on how to overcome these barriers and see that the use of guidelines increases, the question of whether the use of guidelines leads to improved patient outcomes threatens to be overlooked. This is especially important since the effect size of a certain guideline adherent treatment delivered in clinical practice may be critically smaller than the effect size of the same treatment on which that guideline was based. Evaluated in an efficacy study. This efficacy versus effectiveness. I could be screwing this up, but efficacy, as far as I'm aware, is in the lab setting, and effectiveness, or say in the experiment setting. Effectiveness is, say, out in the free living setting, more in the clinical setting. This efficacy versus effectiveness study difference may be caused by a higher degree of heterogeneity of the samples included in the latter type of study associated with the larger standard deviations and the smaller effect sizes. Heterogeneity, difference. The latter study type is the effectiveness study. That's out in clinical land with larger standard deviations and the smaller effect size. So when you go and you look at actual patient populations and try to do the same thing to them, it looks like a smaller impact because it damn well is, because the goddamn people are different. This is basics. This is basic stats, man. And if you like stats so much and you want to do systematic reviews, you should just already know this. It is therefore relevant to examine whether adherence to evidence-based guidelines in everyday mental health clinical practice is superior to TAU. TAU or TAU is treatment as usual at the patient level. Okay? I'm going to roll around here, just kind of blah, blah, blah. Methods. The primary outcome measure was the presence and severity of psychopathological symptoms measured at the patient level with a validated and reliable rating scale. If an included study measured patient health outcomes with more than one rating scale, we chose the scale that was most frequently used by other papers included in this meta-analysis and systematic review. Why would you use the scale that was used most commonly in the other ones? So the math is easier. Not because there isn't important information in the other scale, but because you're making a value judgment that you want to make your math easier. So secondary outcome measures were time to remission measured at the patient level and adherence to the guideline and or algorithm at the provider level. We also explored whether the effectiveness of these guidelines/algorithms was related to the type of mental disorder, the country in which the study was conducted, and the type of control condition. I'm not going to do that. 2.3 eligibility criteria. Studies were eligible for inclusion if they evaluated the effectiveness of an evidence-based guideline or an algorithm-based intervention on the severity of psychopathological symptoms measured at the patient level. This is not studying evidence-based medicine. It is not, because they have had to broaden their definition to use step-by-step approaches and evidence-based guideline, effectiveness of an evidence-based guideline. I need you to understand that this means that they've done some hand waving. This is not doing what you think it's doing. This is doing something else. It's creating an operationalized definition so that they can include some information. This now is studying standardization of approach with weird words. This is a standardized approach. They're looking for an algorithm-based or an evidence-based guideline. Algorithm-based is step-by-step. Do this, do that, do this, do that. Standardized. Evidence-based, standardized, based on best available evidence at the level of clinical practice guidelines as aggregated through an aggregation of systematic reviews. This is standardization of approach. That's all this is. This is not studying evidence-based medicine. So my confidence is gone that this is something that's going to properly represent evidence-based medicine. It's properly representing standardization of approach, which I already know through much less patient population is a consistent phenomenon because I've seen it in multiple places. It's called consilience. Multiple forms of experimentation, multiple forms of data gathering point in the same direction, which means it's likely an omnipresent phenomenon. It's not evidence-based medicine. It's standardization of approach. Okay. Patient health outcomes should be measured with a validated and reliable rating scale. The guideline or algorithm should be mainly delivered in a mental health care settings, included were adults greater than 18 years with a primary mental disorder diagnosed with a structured clinical interview according to ICD or DSM criteria. The following study designs were included: cluster randomized control trial, CRCT, cluster non-randomized control trial, CNRCT, and controlled before and after design. Systematic reviews, meta-analyses, secondary analyses, cost-effectiveness studies, conference abstracts, and case studies were excluded. Meta-analyses were excluded because they don't tell you the primary information. We included papers written in English, German, French, and Dutch. That's actually awesome because if you can read it in different languages, not only do you get a larger sample size, or have access to a possible larger sample size, but you may also be able to see things cross-culturally. That matters. So that's good. Definition of guideline 2.4. In this study, interventions were considered to be evidence-based guidelines or treatment algorithms when they consisted of systematically developed statements to assist practitioner decisions about appropriate health care for specific clinical circumstances. Standardization of approach. And when these statements were used to provide treatment steps delivered in a particular order in case of non-response, we considered an evidence-based guideline to be developed in a systematic way when in the manuscript references were found on papers evaluating or developing steps of which the guideline was composed. Studies that met these predefined criteria were included regardless of the explicit use of the term guideline or algorithm. Studies evaluating only one component from a guideline, e.g. only one type of drug, were excluded. So they're trying to get a fuller complement. There's a couple in here that actually look at the treatment as usual. Where are we? Characteristics of the studies should be here. Okay, so this is down further. This is in 3.2. Because two studies presented two head-to-head comparisons by comparing an active strategy versus TAO or treatment as usual, as well as an active strategy versus passive strategy. The total number of comparisons is 20. The TAO. Is there anything other than... Oh, no. I need to read better. In 16 studies, the intervention condition was compared with TAO. That's important. While 4 studies evaluated head-to-head comparisons of an active with a passive implementation strategy. The treatment as usual matters because then I can actually determine epistemologically. And when I say epistemologically, what I mean, what can be known, how can it be known, and who can it be known by? If I'm going to have any confidence whatsoever that the operational definition that they've used for a standardized approach to care, not evidence-based medicine, a standardized approach to care, if I'm going to have any confidence, I need to see that in action against what it is being claimed to be better than, and I need to see it better. And I think they see some of it better, right? But it's not necessarily gigantic. Yeah. 'Cause, 'cause I'll need to do that. Patient level. I'm gonna go down to the discussion. I think that'll do what I need. Adverse events, dropouts, methodological quality discussion. The systematic review and meta-analysis examined the effectiveness of evidence-based guidelines at the patient level and found a statistically significant effect for these guidelines over tau d 0.29, confidence interval 0.19, whatever. I'm going to screw that up. I'm going to misinterpret that. We tried to relate these patient-level outcomes to changes in the guideline adherence rates to the mental health professionals and found that the providers in the guideline condition were significantly more adherent to guideline recommendations than providers delivering treatment in tau. If they weren't, then we'd have a problem. Then I wouldn't be able to have any confidence. So if the practitioners following the guideline are not adherent, or they are adherent and the professionals in the treatment as usual are adherent, then no, just give me a break. I kind of want variance. I want the treatment as usual people to be different. I want the people in the guideline condition to be rigid, like very rigid, so that I can actually see that they're better, or if they're better. Suggesting that more adherent provider behavior may contribute to improved patient outcomes. However that may be, outcomes at both levels only correlated by 0.3, indicating that other factors may influence outcomes at the patient level as well. I can stop there, because if I'm trying to increase my confidence that it is specifically the adherence to the practice guidelines, which is a standardization or standardized approach for care, not evidence-based medicine, right? Not necessarily a CPG. It's not really what's happening here. It's a standardization of approach. That is the more appropriate category to view this through. Then what I need is a stronger correlation, and I need to have confidence that it couldn't be other factors that include the patient, that just what the patient may be doing. So the patients in the guideline group may be behaving differently, and the correlation is low. So I cannot claim that I have fully and deeply looked at the impact of clinical practice guidelines on patient outcomes. I cannot claim that. But I can claim that in what little I have done directly in front of your face, my concerns have not been minimized. My concerns have not been allayed. I have the exact same concerns. The exact same concerns being that we're washing things out, that we're trying to normalize to increase signal, which means that we're ignoring the practitioners, how they actually work. We're ignoring the patients and the variability between them. My confidence has actually gone up that my concerns are real and omnipresent because of some of the stuff that I read in front of you. So as it stands, clinical practice guidelines and patient outcomes have not increased my confidence that evidence-based medicine as an aggregated concept is doing anything better than what was done before or than what is being done. If we look at error reduction in medicine, there's two things. It is a standardized approach to care. Essentially, what that does is it means that everybody on the team knows the same steps. So if anybody on the team makes an error, anybody on the team can identify it, provide correction, and fix it, right? Oh, that's evidence-based medicine because they're using a standardized approach from best evidence. No, it's a standardized approach. There's a more appropriate category for this. The other thing that drops medical error is increased expertise, which is accrued across time and experience. Therefore, clinical expertise reduces errors. I need to lean into clinical expertise if I see that. I do need to lean into standardized approaches, especially for novices, but the experts less likely to screw up because they're smarter, they're better, they know more. So unfortunately, right now, my confidence has not increased about the impact of evidence-based medicine as an aggregated concept on patient outcomes. Yes, there's some signal, but it's generally weak signal, and it's riddled with the issues that I thought it was riddled with. Now, is it possible that because I haven't read everything, that I'm missing something, that I'm wrong? It's 100% possible. So we could find out across time. I can look at more of it, but I'm attempting to show good collegial behavior because somebody suggested that's where I should look. I looked. So far, I'm not impressed, right? But I will support standardization of approach for reduced medical error or reduced healthcare error. I will stand behind a consistent, stable approach or a standardized approach for better inter-rater reliability. I will absolutely stand behind that. Depends on exactly what you're measuring. And I will stand by a standardization of approach, making people able to identify and help and learn between one another so we improve multidisciplinary and team-based healthcare. I'm okay with that. But that doesn't increase any confidence in the term, concept, and approach of evidence-based medicine. So if you listen this far, you're a damn champ. I appreciate it. Thank you for listening this far. Hopefully you've learned something, and we'll talk again soon.